Lisa, thank you for kicking us off this morning by talking about end-of-life care.
Thank you, Lori. Really appreciate that introduction. And it's a real pleasure to be here to speak with everybody about end-of-life care, and in particular, sharing with you a framework for advanced care planning conversations. This issue has gained even more importance in light of COVID-19, given the staggering number of patients who have been infected and many of whom, unfortunately, succumb to the virus. So I hope that you'll take away from this a very practical framework for how to engage your patients in a conversation about their preferences and goals for end-of-life care.
Hey, Lisa, wiggle your mouse and click and make sure you can change.
I have no disclosures. And as Lori mentioned, I am an employee of the federal government working for the Veterans Health Administration, and the views that are expressed in this presentation are mine and not those of the government. So what is advanced care planning? I think most importantly, it's important to remember that this is really a process. It's a process about making decisions about care that patients would want if they become unable to speak for themselves. And the outcome of that process, of that conversation, and in many cases, multiple conversations, is the advanced directive document that should be put in a patient's electronic medical record and also shared with family members. That process should be based on a patient's personal values, preferences, and discussions with you as their physician, as well as their loved ones. So what are some of the indications for advanced care planning? And this was a paper that was initially published in JAMA several decades ago now by Timothy Quill. And I've added to this what I think is the most obvious indication right now, which is certainly any hospitalized patient with COVID-19. And I would go beyond that. We in the VA healthcare system have proactively gone back to all of our patients, reviewing patients with comorbidities and ensuring that those who are over 65 have had a conversation about advanced care planning. So certainly any patient who's hospitalized with COVID-19 should have a conversation about their preferences and goals, a goals of care conversation, an advanced care planning discussion, and generate an advanced directive. And it's ideal to really have these conversations in an outpatient setting. So we shouldn't be waiting for patients to come into an outpatient setting. And if you're seeing a patient who has been diagnosed with COVID or is at high risk for COVID, I would strongly encourage you to engage them in a conversation about advanced care planning. Whenever you're discussing a poor prognosis or you're discussing a treatment that has a low probability of success, that is another indication. And the literature has demonstrated that asking yourself the surprise question is a great way to identify which patients would most likely benefit from having a conversation about advanced care planning. And that surprise question is asking yourself, would you be surprised if the patient died in 6 to 12 months? If your answer to that question is no, you would not be surprised if the patient died in 6 to 12 months. That should ring a bell for you and encourage you to engage in the conversation with the patient. We can also say that whenever you're reviewing the healthcare maintenance with a patient, there's an opportunity on an annual exam to discuss advanced care planning. There's also clearly some urgent indications, which is when a patient is imminently dying, when a patient may ask us and start talking about wanting to die, and when someone's been recently hospitalized for a severe prognosis or they're suffering and have a poor prognosis. So these are all indications for us that we should begin to have this difficult conversation with our patients. Well, what are some of the benefits of advanced care planning? Why should we do this? And I think that you can really think about this in three different levels, really. There's benefits to patients, there's benefits to healthcare providers, and there's benefits to family. So first and foremost, for patients, this really promotes patient autonomy. It gives voice to patients' preferences when they cannot speak for themselves. And it really gives patients peace of mind that their preferences will be respected when they can't speak for themselves. There's also benefits to healthcare providers because by having these conversations when a patient can speak and engage in a conversation and share their preferences, it ultimately avoids confusion and conflict when a patient loses decision-making capacity. This gives healthcare providers a clear roadmap and allows healthcare providers to make decisions that are consistent with the patient's preferences. There's also benefits for family because when patients articulate their preferences in advance, it really decreases the angst of family members so that they don't have to second guess their family members about what the family might have wanted, and that they really have guidance directly from the patient about what decisions to make at the end of life. As a result of that, it diminishes family guilt if treatment is limited, and that can be a very hard decision for family if they don't have guidance from the patient, him or herself. I want to share with you a little bit about the outcomes of advanced care planning because there's been multiple studies over the past decade that have looked at what are the clinical outcomes of advanced care planning. And here's, I've given you some of the references as well as highlighted some of the benefits. First and foremost is there's decreased ICU admission, right? If we engage our patients in this conversation about their preferences, we come to understand that many patients do not want ICU admission. And this has become extremely important in the COVID-19 era, where in some cases there were many concerns, and if we have a second wave, there will be ongoing concerns about limited resources, scarce ICU beds, scarce ventilators, and really being able to engage patients in a conversation and understand, do they even want to be admitted to an ICU? Do they even want a ventilator? That's going to help us triage patients and allocate our resources in an equitable way. Advanced care planning has also been associated with improved quality of life, increased hospice use, and it also improves family bereavement outcomes. And this is really, really interesting, and in part by including family members in the process of advanced care planning, making sure that they're aware of the patient's preferences, they are more easily able to come to terms with the death of a loved one. And importantly, the research has also shown that raising this difficult topic of advanced care planning and patients' preferences at the end of life does not hurt the therapeutic relationship between a patient and their healthcare provider. So that should give us some renewed impetus and encouragement to have these conversations despite their being somewhat difficult. So I wanted to share just a few key principles for advanced care planning conversations before I share with you a very structured framework for how to have these conversations. And these are key principles to just keep in mind as you have these conversations and go through the different steps of that framework. The first is the principle of ask, tell, ask. And this is a communication principle of how we should engage our patients, beginning with asking our patients a question, telling them information using succinct language that's non-medical, that they can really understand, and then asking a follow-up question to make sure that they've understood it. So for example, before we embark on a conversation about advanced care planning, we might ask them, would it be okay if I asked you about your goals and values? And then engage in that conversation, give them feedback if they have questions, and then ask them again about what's important, given the information that you've given them, making sure that they've understood what you've shared. So that framework and that concept of ask, tell, ask can be very, very helpful as you move forward with this structured process. The other thing that we've found from the literature and from experience is that it's critical to respond to patients' emotion. And so often when we're engaging in a conversation about end of life, there's a lot of underlying emotion that may actually get masked by questions about data, and that it's important to try and tease out the emotions that underlie our patients' questions. And we can, when we want to respond to emotion, there's certain techniques that I think I just want to highlight for you. First is naming the emotion. If you can tell by a patient's voice that they're worried, acknowledging that, saying, it sounds like you're really worried about whatever the issue is that they're discussing, whether it's their spouse who may not be able to handle their imminent death, their children, their pets in some cases, or naming that they're feeling overwhelmed. So naming that emotion can help alleviate anxiety. Expressing your understanding of how difficult these conversations are and how difficult the predicament is of being at the end of life by saying things like, I can't imagine how difficult this is, or acknowledging that this would be difficult for anybody and everyone, I think can really help develop a rapport and put our patients at ease. And then lastly, I think silence is another really important factor to bring into your conversations with patients. Sometimes we as physicians speak too much, we're uncomfortable with silence, and we jump in and we don't give patients the space to self-reflect and to share what they really think is important. So don't be afraid of silence. I think about it as kind of like the pause in a piece of music, right? That pause carries great significance and conveys information. So give your patients some space and don't be afraid of the silence. So here's a stepwise framework for advanced care planning conversations. And the first step is to ask permission to discuss advanced care planning. Some patients may not be ready for it. And if they happen to respond that no, they really don't want to engage in it, then you have to respect that, I think. I would share information either in paper or point them to electronic sites that they can begin to think about it, encourage them to begin talking about it with family members, and then perhaps on the next visit to discuss that with them again. The next step is to really solicit the patient's understanding of his or her illness. It's important to really know where is the patient in terms of understanding their progress, their prognosis, so that you can then help inform that and correct it gently if they're off base. The next step is to assess if the patient has a healthcare agent. And this is really critical because we know that many patients at the end of life ultimately lose decision-making capacity, and we need to rely on their healthcare agent in order to guide our decisions at the end of life. So if they have not identified a healthcare agent, then we need to encourage them to do so. And more importantly, it's not just about picking someone to be the decision maker. It's about encouraging the patient to actually have a conversation that's meaningful about their preferences, about their goals and values, about what they would want when they get to the point where they cannot speak for themselves, so that that healthcare agent is really empowered to make a decision on behalf of the patient. The next step is to elicit the patient's goals and values, and I'll take a much deeper dive into this, giving you very specific questions to help you have this conversation. I really think this is the crux of advanced care planning. After you've solicited patients' goals and values, you try and synthesize that and offer a prognosis. It's important here to share information on outcomes. And if you happen to be a primary care provider and a patient has a very rare oncological diagnosis and you're not sure of the prognosis, or you might not be sure of their prognosis in any other area, don't be afraid to acknowledge that and to seek guidance from your specialty care colleagues, because understanding the prognosis and making sure that the patient has an understanding of their prognosis is really essential to their decision-making about next steps and what decisions they should and what you recommend they should make based on their goals and values. It has to incorporate a realistic understanding of prognosis. After you've gone through those 5 steps, the next step is to really synthesize it all, put it together, and make a recommendation based on the patient's goals and values to then summarize it. This comes back to that principle of ask, tell, ask, right? Where you're sharing information, you're asking if you've got it right, and you're trying to correct any misunderstandings. The next step is to really document the goals and values in the electronic health record, and then to apply the directive when the indication arises. I want to just share with you a framework for discussing goals of care. And this is a way to structure the different priorities in your conversations for medical care. I think it can be very helpful when you're talking to patients about their goals of care to break it up into these 3 buckets. One bucket is living longer, where you ask the patient, are they interested in focusing on living as long as possible, even if they may not know who they are, and even if they may have to be in a hospital indefinitely and connected to machines. So where their goal is to live longer, no matter what the quality of life is. A second bucket is really where the focus is on maintaining their current health. So they may want to live longer, but they really are also focused on their current quality of life, and they want to ensure that they're not going to have any further decline in their quality of life. They may be willing to go to a hospital if they need to have effective care, but they also may be open to stopping treatment if it's going to diminish their quality of life. So the focus is on maintaining their current state of health. The last bucket that you can break things up into for patients is, I think, a focus on comfort. So some patients may want to be at the point where they say they've lived a full life and they really want to focus on comfort and quality of life. They don't want to go to a hospital. They don't want to be admitted to a hospital. They don't want to be connected to any machines. And they really want a more natural death at home in many circumstances. So this is a way to just help frame the options for patients in terms of their goals of care. So what are some ways in which you can elicit goals of care with patients? And I would encourage you to have at your fingertips, when you have these conversations, a series of questions to help guide your conversation. And as you do this and as you practice it, eventually this will become second nature and you won't need to rely on that cheat sheet. But asking patients, what are your goals for treatment? And breaking it up into those categories that we just spoke about can be helpful. Are you interested in living longer? Are you interested in maintaining your current health? Or do you really want to focus on comfort? What do you want to accomplish with your healthcare? That's asking an open-ended question like that can really help elicit patients' goals. And then really trying to get patients to think about, are there any health situations that they would find unacceptable? For example, many patients don't want to be dependent on others. And if they're unable to interact with people and can't communicate, that would be unacceptable. If they couldn't care for themselves, they might find that unacceptable. So really trying to tease this out with patients will help you synthesize their goals and values and make a recommendation to them about what would make sense given their goals and given their prognosis. The next part of this is also eliciting patients' values. And here's a series of questions that can help you really elicit the patient's values. And I think that this is important because so often patients can't patients and we as healthcare providers can't always predict the decisions that we might encounter at the end of life, right? We might know, okay, do you need a ventilator or you don't need a ventilator? Do you want to have CPR or you don't want to have CPR? But sometimes there's nuances that we can't predict. And really understanding patients' values can go a long way to helping us as healthcare providers, as well as helping healthcare agents and surrogate decision makers, family members, make decisions. So asking patients about their beliefs or any wishes that we should know about can be helpful. Asking them what they're really hoping for, and is there anything that they want to avoid? So when they think about the future, what do they hope for? And when they think about the possibility of getting sicker, what are they most worried about? And if their health gets worse, what is really important to them? Helping them, asking them these general questions is a way to help them engage in reflection, to elicit their values, help them think through what's important to them, and help them identify what their particular end-of-life plan should look like. So the next step after you've elicited goals and values is to really talk about prognosis. And there's many different tools out there to help guide you in that conversation. Since so much of our end-of-life care oftentimes focuses on CPR, I think it's important to be aware of the data that exists about CPR so that you can share that with patients. I hope that your conversations about end-of-life care go way beyond talking about code status, right? Ultimately, it's about goals and values. And at the same time, we do need to make decisions and put in information about a patient's code status. So this is a study that was published about a decade ago in the New England Journal of Medicine. It looked at Medicare data on about 430,000 patients who had in-hospital CPR. The patients were over 65 years of age. And overall, survival to hospital discharge was 18% in this category of patients. So it's not zero, right? Patients can survive, even elderly patients. And at the same time, it's a relatively low percentage. So 80% of patients who undergo in-hospital CPR are actually going to end up not surviving to discharge. I want to just share with you some of the outcomes that we've recently garnered about for COVID-19 patients. And if we look worldwide, you can see that the case fatality rate is anywhere between 3 and 7% internationally. Within the US, we've actually done better than that with about a 3.4% case fatality rate. And as you can see here, the hospitalization, this is the broken up in US outcomes in the United States, COVID-19 outcomes by age. And you'll see here on the left, the age groups from 0 to 19 up into greater than 85. And then the hospitalization rate, percentages of hospitalization, ICU admission, and case fatality rate. And what you'll see here is that as age increases, we have an increasing amount of hospitalization, ICU admissions, and case fatality. And this reality, this unfortunate reality, really should inform our conversations with patients about advanced care planning, right? Our elderly patients are at greater risk for hospitalization, ICU admission, and ultimately a death secondary to COVID. What about, in general, outcomes of in-hospital CPR in the United States? How has this changed over the past, over a decade? And this is data that was published in 2013 that looked at in-hospital CPR outcomes from 2000 to 2009. And what it showed was that while survival actually increased from 20% to 29%, so more patients were surviving, and there was a decrease in those who were discharged to home. And this goes to quality of life. The main point of this slide is to drive home that while more patients may be surviving in hospital CPR, their quality of life is actually diminishing. So we know that many patients actually prefer to die at home, and yet the discharge to home actually decreased from 36% to 24%. The discharge to hospice actually increased from 0.4% to 7%, and to long-term care facilities from 1% to 9%. There was also a significant increase in neurological compromise by 38%, and the use of feeding tubes and ventilators significantly increased. So as we're having conversations with patients about code status and the use of CPR, it's important to focus not just on the short-term survival, but also on their long-term quality of life and their long-term survival and where that survival might be, and the reality that many of them are not going to get back to that level of independent function or prior level of health that they may have had before CPR. And I think that that's an important context that our patients would likely want to know about, and that we as healthcare providers should be sharing with them. I want to share with you just a website that can be very helpful in terms of your conversations about prognosis with patients. eprognosis.org .ucsf.edu was developed by clinicians at UCSF. It's a tool for estimating prognosis, especially for elderly patients, because it has a repository of geriatric prognostic indicators, and it really helps guide healthcare providers about mortality outcomes. It's been internally validated on several 100,000 nursing home residents. And if you're striving for information to help guide that conversation about prognosis, this is a very helpful website that I would point you to. So the next step after you've talked about goals and values, if you've elicited their understanding, talked about goals and values, talked about prognosis, is to really make a recommendation. I want to clarify here that you shouldn't be afraid that by making a recommendation, you're somehow undermining the patient's autonomy. Ultimately, at the end of the day, the patient can decide and has the right to decide what they want, what kind of end-of-life interventions they want. You're making a recommendation based on what they share with you and your understanding of their prognosis and their likely outcome and their quality of life is purely that. It is just a recommendation. At the end of the day, the patient has the full authority to decide, do they want a ventilator? Do they want to go into the hospital and have care in an ICU? That is their decision. So making a recommendation is not inconsistent with patient autonomy. That recommendation should be based on the clinical situation, patient's goals and values, and you should summarize that and explain how you got to that recommendation and give the patient an opportunity to correct it if it's not consistent with what they really want. It's a way of offering guidance to patients. I think patients come to us as healthcare providers because they're seeking our expertise. And it often relieves patients and families of the burden of making a decision. So it can be helpful for them to know that you agree, or this is what you think, given your expertise, is in their best interest. This is just a summary of the questions to guide your conversation for advanced care planning. And I would encourage you to print this out, to keep it at your side or up on your computer screen as you're doing your telehealth visits now during COVID. And it can help really take you through this entire process. So in summary, advanced care planning is really more than just filling out a form. It's a process of understanding your patient's values and goals. And that really begins with what the patient understands. That's your starting point. We really should be listening more and speaking less. Don't forget to make time for that silence and giving patients the opportunity to express their emotions, their fears, and their hopes. Sharing prognostic information is really important here, and information about data on CPR outcomes, and not just short-term outcomes, but also the long-term outcomes is helpful. Including family members in the conversations is really, really critical. And if a family member, I like to ask patients to bring a family member to the visit. You can even have the family member included in that telehealth visit that you might be doing. And that way the family member actually hears everything that you're sharing with the patient and hears what the patient is telling you about their preferences. That really makes decision-making at the end of life when a family member, when the patient loses decision-making capacity, so much easier because everybody's on the same page. And then finally, it's critical to make a recommendation and document patients' preferences. So I'm going to move on to a few questions. The first questions, and I hope that everybody has the ability to respond electronically, is so you have a patient with advanced multiple sclerosis who has developed renal failure, secondary to diabetes. The patient is DNR, do not resuscitate. She presents to the emergency department unconscious with a potassium level of 8 milliequivalents per liter. What is the most appropriate next step? A, no intervention because she is DNR. B, discuss a reversal of the DNR order and dialyze the patient. C, proceed with dialysis. And D, give some sodium polyestrine sulfonate or Kayexalate until you can find the healthcare agent to discuss dialysis. I'll wait a moment here while people vote. And Joe, do I advance it or do I let you advance it? Okay, it looks like people are still voting, so I'm going to give it another second, I think, because we have a little bit of time. Okay, so I'm going to go ahead and go to the next slide. So so just to remind people there, about 75% of people actually chose D. That is not the correct answer, and the correct answer was C, and we'll talk a little bit about why. So the correct answer was proceed with dialysis, and about 20% of you identified that as the correct answer. So the reason why D is not the correct answer is because this patient is presenting with life-threatening hyperkalemia. And while Kayexalate can treat hyperkalemia in general, it's inferior for the long-term management of renal failure. And given the life-threatening presentation of this patient, dialysis is the intervention that would be indicated. Now, let's just go through the other responses more systematically here. The first response of do not resuscitate is a DNR order is specifically defined as refraining from cardiopulmonary resuscitation. So even though this patient had a DNR order, that does not mean you should not treat, right? That does not mean that we should not proceed with dialysis. DNR only means we should not do CPR. The DNR order should prompt that conversation about patient's goals and raise the question about whether or not maybe she intended comfort care only, but it does not mean that we should not treat with dialysis. So the correct answer here is to proceed with dialysis, and then you can certainly revisit the patient's preferences and discuss whether or not they want continued dialysis. I'm going to move on to the next question. A 29-year-old man sustained a C1, C2 spinal fracture during a boxing championship 3 months ago. He is paralyzed from the neck down and is ventilator dependent. He's fully alert and understands his condition, and he requests removal from the ventilator and understands that he will die as a result of being removed from the ventilator. So what's the most appropriate next step? Assess for depression, and if no evidence, remove from the ventilator as requested. Obtain a court order to continue the ventilator. Seek family consensus on removing the ventilator. Seek approval of the healthcare agent. So I'll give it a few seconds here to go ahead and vote, allow people to vote. And given that my time is up, I'm going to move on to the next slide. The vast majority of people got this correct. Assess for depression, and if no evidence, remove the ventilator. Let's just talk for a second about why that is. So the case involves an adult patient that has intact decision-making capacity and understands the implications of withdrawing the ventilator, and therefore has the right to do so. It's important to recognize here that from an ethical perspective, there's no distinction between withholding and withdrawing the ventilator, and that patients, it is important to recognize that patients are frequently depressed after a high C-spine injury. They do adapt to it, but it is important to screen patients for depression. And given that the patient is alert and has decision-making capacity, there is no need to engage the healthcare agent or other family members to request permission for this. I'm going to stop there and happy to take any questions.
Lisa, thank you so much. In the interest of keeping us on time, there have been some questions, so I want to acknowledge that from the audience, and we will address those at the end of the session. This was amazing. It's always wonderful to hear you speak about this and to really think about how important this is in the work that we all do every day.